Pleasant morning to everyone. I am lovely Gupta. So,
Excuse me, can you set the timer back again? I think it is at 4:46.
shall I start? Good morning, everyone. So, my topic is effectiveness of enhanced usual care education intervention among adults with type 1 diabetes mellitus. So, here comes the introduction. India is second largest country having diabetes after USA in young age group. So, people on insulin regimen are required to be well compliant with proper daily insulin treatment, regular blood glucose monitoring, maintenance of healthy diet, lifestyle is a part of their diabetes self-management, so that there is lower frequency of diabetes associated complications, increased quality of life and decreased healthcare cost. So carbohydrate counting is one of a meal planning technique which is used for adjusting insulin dose with respect to carbohydrate content of meals to maintain optimum blood glucose levels. So objectives of my study were: broad objective was to assess the effects of imparting the enhanced usual care education intervention on diabetes management and metabolic risk factors of the participants. The specific objectives were to see pre and post intervention changes in HbA1c, their insulin dose, hypoglycemic episodes, metabolic risk factors, knowledge attitude practices, that is CAP, diabetes self-management scores, diet and physical activity. So this is a methodology. Recruitment was based on eligibility criteria, which will come in following slides. Enrollment was done from AIIMS, New Delhi. Patients were randomized and allocated into control arm and intervention arm. 3 sessions were given on standard care and 3 sessions on standard care plus additional sessions on carbohydrate counting. So this was a randomized controlled trial which were followed by after 3 months and at the end of study, which was 6 months. Sample size came out to be 130. Inclusion criteria had people with type 1 diabetes, and adult age group was taken 18 to 40 years and HbA1c of more than 7.5%. Data was collected using standardized questionnaires and tools. Primary outcome was difference in proportions of individuals between two groups who achieved HbA1c reduction of 0.5% or more at 6 months. That is end of the study. And secondary outcomes included difference between two groups in terms of mean change in various metabolic, dietary, diabetes related clinical parameters and various scores of various questionnaires and the add-on the study. So these are the baseline characteristics of my study. In case only hypoglycemia was seen to be significant different, and that's why it was adjusted in following outcomes. Effect of intervention on primary outcome, HbA1c. So there was although no significant difference among the groups when ITT, that is intention to treat and per protocol analysis was done. We can see it through mean plus minus SD, but there was improvement seen in difference and adjusted difference among both the groups. This is the forest plot which is shown for adjusted and unadjusted variables in ITT and PP analysis. So there was significant difference in the same group, more in intervention arm, as we can see. So proportion of individuals who improved with more than 0.5% were also more in the intervention arm, as we can see from this table. Similarly, when the achievement of HbA1c was seen among patients of both the groups, there was more improvement in HbA1c, that is 71%, as compared to 62% in the intervention arm. And when achievement was seen from those who actually followed our intervention, that is who actually calculated and accurately counted the carbohydrate, so HbA1c was mostly improved in those people, and there was a more difference and more improvement in those people, although the number was significantly less. That was only 31 out of 134 patients which I recruited in the beginning. So effect of intervention on metabolic risk factors, triglycerides and VLDL improved well only in intervention arm. Somehow BMI, waist circumference, systolic and diastolic blood pressure remained unchanged and were maintained in their ideal range. Total cholesterol and LDL improved in both the arms, and HDL reduced slightly, although, but it was an insignificant difference. So when effect was seen on secondary outcomes, CAP, healthcare use and some scale score of diabetes management improved more significantly in intervention arm. Fasting, pre-meal, post-meal blood glucose and glucose management score, dietary scores, physical activity scores improved in both the arms. So we can see from here there was a significant difference in these parameters. Predictors were also calculated for my part. So multivariate analysis showed that positive attitude was independent factor which may be responsible for decreasing the chances of deteriorating HbA1c. But bivariate also showed that employment and low socioeconomic status had higher odds of favorable outcome, which was more than 0.5 reduction in HbA1c. Sensitivity analysis was done because of pre-COVID and post-COVID effects. So although there was no significant impact in HbA1c, which was seen for effects of pre and versus post-COVID, for those who attended sessions on virtual mode, because we shifted to mixed modes also, like online mode for the people who were left for the intervention, and for those who attended all the sessions versus those who attended partially. So that could be due to because repeated reinforcements and follow-ups were given by me on the telephone. So the conclusion was enhanced usual care with education on carbohydrate counting is beneficial for management of type 1 diabetes. There may reduce diabetes related complications, cardiometabolic risk factors, along with improvement of diabetes self-management skills among them. So this is one of the new study which is being conducted in South Asian region. So I also conclude that maybe once conducted such studies among larger number of people and followed for longer period of time, they may be directed towards significant management of diabetes outcomes. Just I'm left with a few references, which is not moving, and that's all I'm done. Yeah, so a few references. Thank you.
All your patients were on the, what insulin regimen were they on? They were on type
They were
1s,
on
right?
bolus and basal regimen.
All of them were on
All
basal.
of them. Because we had to calculate carbohydrates, so that's why we purposefully took bolus and basal regimen people, and then we randomized them.
What was the major difficulty you faced? You said only 31 children or families were actually doing it the right way.
Ma'am, that was because among 134, first of all, we randomized them into control arm and intervention arm. So I was left with 68 in intervention arm and 66 in control arm. And then when I actually saw, and in the follow-ups, when I actually calculated how much are you eating from your own meal, they actually either overestimated or underestimated, or they said they don't remember the carbohydrate calculation yet. So for those who actually calculated well and those who had it accurately answered, for them we had a significant reduction in the HbA1c. That's why we explored it further.
That was only 50% of the ones who were randomized into
because
that
they only followed actually. So maybe
how,
the intervention
how do
time
you
was
infer that? Like, what is the practical application of this addition in your routine clinical practice?
Ma'am, I didn't understood, sorry.
Only 50% were able to follow your enhancement of the diabetes care that you're giving. So how will it translate into clinical practice?
Ma'am, because maybe the intervention time was less, and also there was in between problems of COVID, so I could not give them more reinforcement. Could be one of the reason. Otherwise, ma'am, maybe we'll continue the study further for another 6 months, because that's a kind of behavior change that whenever you're eating, you have to calculate. So maybe that's why they didn't calculate it well, and it's not easy, like once we tell something to them, it's not easy that everyone will grasp the same thing. I am happy that at least 30 followed me.
Yeah, so in a controlled trial setting, you only achieved 50%.
Yeah.
In real life setting, it's going to be much lower than that.
Maybe, ma'am. Because I was told the same thing when I interviewed many diabetes care team and experts. So they told me even if 1 or 2 will follow, that's a big achievement for you. But somehow 30 did it for me, so I was quite blessed for that.
How many were doing carbohydrate counting in the control group?
Sir, in control group they were not doing.
They were not doing.
No.
None were following
None of them
at the
were
baseline.
doing. No, sir. I actually, in fact, before this data which I could not present, I visited many hospitals like private as well as government sectors. So carbohydrate counting was not at all practiced. Only in one study, one clinic they told me that they are trying, but the results were not that significant because people are lost to follow.
Was there any difference in the SMBG monitoring in the
Sir,
control?
there was somehow I could not show because I had so many secondary outcomes, but we checked the frequency of SMBG. There was improvement, but the improvement was again in both the groups because we were giving enhanced usual care to both of them.
No, was
So
there
that improved.
Was there any difference, significant difference?
So there was not significant difference somehow.
Just a couple of questions. Number one, how did you randomize? Again, this is a...
So we randomized it using nQuery software into one group, and then we randomized it using SNOP, that is sequentially numbered opaque envelopes that we gave them.
All right, so it's
In
a
the
very
beginning
good
of the
method
study.
of randomization.
Yeah.
Okay, next question I have is there any other structured program elsewhere in the world that you looked for which...
Sir, we looked for, but we could not have the practical aspect of it because I was based in India. So I tried to look at the hospitals who were covering good diabetic patients, type 1 patients in Delhi.
Okay.
So I tried to visit them, like I went to Max Hospital, I went to Venkateshwar Hospital, I went to that Kalpariksh lab which is there, because they were doing carbohydrate counting. Actually I went to AIMS because that was my nodal site, and we also went to Maharaja Agrawal Hospital. So I covered many hospitals till the time I got the saturation for my people.
Okay, any techniques you know worldwide which they use for carbohydrate counting, structured learning programs?
Sir, yeah, sir, one Bertie is there. IDF is conducting many programs. Even this American Diabetic Association is doing many programs. But in South Asian country, I could not find a very reliable one where I could go and have the practical experience of.
Okay.
So that's why I chose this topic.
So once you finish your PhD,
Yes, sir.
do you think you'll be able to formulate a more effective
I believe, sir.
carbohydrate
Although that
counting
takes a little
program
bit
for India?
patience, and that will take a little bit efforts, and the results may not be immediate, but I'll be patient enough for the same, because I believe my patients were really happy and they still connect me for the same.
Okay.
Because maybe they have understood the logic of diet somehow behind their HbA1c and their insulin doses.
All right, thank you.